I'm going to go ahead and get started. This is Commander Angela Fallon. I am the Deputy Director for the Office of Clinical and Preventative Services. The OCPS team is excited about sharing information about new funding and new opportunities. We have a ton of information to share with you all. And at the end of the session, we're going to have a question and answer. We have a lot of information to share, so we're going to go ahead and get started. And I'm going to introduce our Chief Medical Officer, Dr. Tote. Dr. Tote?
Thank you so much, Commander Fallon. I do note in the chat there was a request from Dr. Ronyak to record the session, so just want to give our technical team time to confirm that that's okay to continue. All right, looks like I've got a green light to go ahead. So good afternoon. I'm Rear Admiral Michael Tote, the IHS Chief Medical Officer. I am happy to be here with you today virtually to speak with all of you and to provide updates on what we're working on at the Indian Health Service. Let me begin by thanking all of you for making the time to attend this unprecedented event that gives us all the opportunity to have a meaningful discussion on two new initiatives. An initiative to address Alzheimer's disease, and an initiative to support ending the HIV epidemic. I want to thank Commander Angela Fallon, Deputy Director of the Office of Clinical and Preventive Services, for moderating today. Dr. Marcy Ronyak, Director of the Division of Clinical and Community Services. Dr. Bruce Fink, Elder Care Subject Matter Expert. Dr. Blythe Winchester, Chief Clinical Consultant for Geriatrics and Palliative Care, also the Medical Director of the Solly Care Center, and the Cherokee Indian Hospital 2020 Employee of the Year. Congratulations, Dr. Winchester. And also Mr. Rick Haverkate, National HIV and Hepatitis C Program Coordinator, who will be presenting the program updates today. I would also like to thank the Division of Clinical and Community Services for their most diligent efforts to provide our virtual meeting opportunity. At the Indian Health Service, we are committed to building, strengthening, and sustaining collaborative relationships that advance the IHS mission of raising the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. A major part of that involves enhancing and ensuring quality of care through opportunities to build or enhance supporting infrastructure and services for the elderly and those living with HIV and hepatitis C. This can only be done by building a robust network across Indian country and collaborating with other federal agencies to help create or enhance services within our communities. In order to provide updates on both elder care and ending the HIV epidemic, the IHS Office of Clinical and Preventive Services will share additional information on both new initiatives, the agency requirements for implementation, and activities to date for each specialty area. The learning session intends to provide an opportunity to expand knowledge and awareness in preparation for the upcoming tribal consultation and urban confer sessions for each initiative. During Tribal Consultation and Urban Confer, we will be focusing on the following areas for feedback and recommendations. For the Alzheimer's Disease Initiative, exploring how the IHS might use available funding to support sustainable, comprehensive models of care for persons living with dementia and their families through IHS tribal and urban Indian health programs. Investing in improving awareness, early recognition, and diagnosis of Alzheimer's disease and related dementias in partnership with tribal communities. Investing in competency-based training for all clinical staff to improve diagnosis, assessment, and management of Alzheimer's disease and related dementias in IHS, tribal, and urban Indian health programs. And investing in evaluation and data to assess the impact of Alzheimer's disease and related dementias, the needs of those living with dementia and their families, and the effectiveness of efforts to address and improve management of Alzheimer's disease. for the Ending the HIV Epidemic Initiative, exploring how the IHS might use available funding to support IHS, tribal, and urban Indian health programs to achieve the Ending the HIV Epidemic all of U.S. goals of a 75% reduction in new HIV infections by 2025 and at least a 90% reduction by 2030. And key strategies of the Ending the HIV Epidemic efforts, including diagnosing all people with HIV and hepatitis C as early as possible, treating people with HIV or hepatitis C virus rapidly and effectively to reach sustained viral suppression. Third, preventing new HIV and hepatitis C virus transmissions by using proven interventions, including pre-exposure prophylaxis and syringe service programs. And fourth, responding quickly to HIV and hepatitis C outbreaks to get prevention and treatment services to people who need them. We know the importance of collaborating and consulting with tribes, partnering with our tribal advisory committees and tribal organizations to gather input on critical next steps and developing a comprehensive plan for addressing both Alzheimer's disease and the Ending the HIV Epidemic in Indian country. Thank you for the opportunity to speak with all of you and to provide updates on the IHS headquarters work around the country. I look forward to our discussions here today. I will now turn the program back over to Commander Fallon. Thank you.
Thank you, Dr. Cope, for that introduction. We're going to turn it over to Dr. Runyak.
Thank you, ma'am. I just want to do a sound check. Can you hear me?
We can. Thank you.
Excellent. Thank you. I appreciate that. Thank you, Commander Fallon, for the brief introduction, and thank you, Dr. Tote, for the excellent opening and words on the work that we've been doing today. So good afternoon, everyone, and welcome to the learning session. This session is divided into two parts. Our first part that we'll be focusing on, as Dr. Tote mentioned, will be the Alzheimer's disease and related dementia. And then we will move into the second part, which is focused on ending the HIV and HCV epidemic in Indian country. Next slide, please. Please note that all external non-IHS links that are included in this presentation do not constitute official government endorsements on behalf of the Indian Health Service. The IHS makes no representation regarding the quality, content, completeness, suitability, adequacy, sequence, accuracy, or timeliness of such information and disclaims any responsibility for the errors. We want to make sure that we are highlighting that all of these webinars are being recorded for on-demand viewing. We will be placing all recordings on the Division of Clinical and Community Services, Tribal Consultation and Urban Confer website. We will also have various updates that will be placed upon that website as well. Next slide, please. As the first part of our learning session, we will be focusing on Alzheimer's disease and related dementias in Indian country. With that process, we'll be providing an overview of the problem. We will be highlighting some of the existing partnerships that have been developed over the years. We will also present a variety of current needs within our communities and host a question and answer session following our second presentation. And again, just as a reminder, that will be us following up on our Ending the HIV and HCV Epidemic. It is with great pleasure for me to introduce Dr. Winchester. I will now turn
Hi, can everybody hear me?
Yes.
We can hear you, Dr. Winchester.
Oh, thanks. Sorry, I hadn't heard a response. Shio Nagata, hello everyone. So I'm just going to quickly go over kind of the scope and just give you some basic information. I'm really excited to be here today, and also thank you to all the amazing people who work, in elder services. You're some of the most passionate, enthusiastic, and amazing people. So please continue to do your great work, and I'm very excited about this to help us in continuing to do that. just to give you kind of an idea of what we're dealing with, you know, the estimates are that by 2050, 13.8% of our country's population will have dementia. The largest increase is going to be in those who are 85 and older. And Alzheimer's disease now costs more to our economy than cancer or cardiovascular disease. In terms of Indian country specifically, you know, our aging population is really growing, and our oldest cohort of adults who are 85 and older, that population is projected to increase more than 7-fold by 2050. Between 2014 and 2060, the number of American Indian Alaska Native 65 and older living with dementia is projected to grow over 5 times. In 2015 to 2017, 1 in 6 American Indian Alaska Natives aged 45 and older reported subjective cognitive decline, so some kind of self-reported difficulty in memory or thinking. And 2/3 of those had to give up some kind of day-to-day activities because of these cognitive problems. This slide goes over kind of the basics of what dementia is. So memory loss and difficulty with some of the following: naming things or people, doing simple mechanical tasks like buttoning a button. That can also include trouble understanding visual and spatial relationships, so having more trouble with balance, tripping over things, spilling or dropping things, trouble with recognizing people or places, changes in behaviors, that also includes changes in mood or personality. Problems with thinking, obviously, as it relates to problem solving or being able to remember certain things, trouble with math, calculating numbers, and then also trouble with planning and organizing. And some of that also includes, you know, trouble with handling bills or even trouble cooking a recipe that you've used for years. The key thing that makes this a dementia is that it interferes with your daily life. So the most common question I get is, what is the difference between Alzheimer's and dementia? The key fact here is that Alzheimer's is a form of dementia of which there are many different kinds. Some of them are listed here, and they include vascular, you know, Lewy body, multiple different types. The number one most common form of dementia is Alzheimer's disease. The following ones are mixed dementia and vascular. What I'll tell you in my practice in Indian country is that we have a lot more mixed dementia than we have data on at this time. The other thing I'll mention is that we also have early onset dementia. And early onset dementia is that occurs in people who are younger than 65 years old, and it's actually one of the fastest rising forms of dementia. So I hope that kind of gives you information, you know, about the scope of this and why we need to be thinking more about it. The second most common question I get is, why do we really need to diagnose dementia? You know, people will say, oh, there isn't a cure for it. Why do I even want to know? It's actually extremely important, and we want to make the diagnosis as early as possible. Other illnesses can cause confusion and difficulties with memory. That includes reversible things. So obviously we need to know if this is a true dementia or if it's something else related to a thyroid disorder or other things. And then understanding what kind of dementia helps us provide better care. Different kinds of dementia have a different time course and set of symptoms. There are different expectations for families, also differences in treatment. It helps to empower patients and families to understand what's going on. It can help you avoid crises, crises even including ER visits, hospitalizations. And the biggest thing is the earlier we can diagnose, even if it's something like mild cognitive impairment, we can really look at your overall brain health and try to see ways we can intervene to prevent the progression to dementia. So the way we make a diagnosis is different for dementia. It's not like heart disease where we have an echo or a stress test or simple labs that we can do. So it's more important with dementia diagnoses to get history, both from patients and their family members, to get a good physical exam. We do use some memory assessment tests to try to get a better picture about what's going on. Sometimes we do lab tests, and occasionally CTs or MRIs are used depending on what the situation is. And then sometimes we may refer people to more extensive testing or to a specialist. So speaking of the diagnosis and specialists, who makes the diagnosis of this? Well, I'll tell you that, my dream is that all primary care providers can make this diagnosis and manage dementia care. A lot of times the diagnosis is made by primary care physicians, geriatricians, nurse practitioners and physician assistants. Sometimes we get the help of neurologists or psychiatrists or psychologists, but you may be aware that a lot of times some of these referral services are difficult to come by, which is why part of this emphasis on awareness and education and that sort of thing is so important. There have been studies before that showed that even when providers feel confident that someone has dementia, some of the time they're not delivering that diagnosis. We want providers to feel comfortable with that. We also know that the best care is team care. This is hands across the board. Care of the individual living with dementia includes care for their caregivers, and I would argue care for even extended people that are involved with that person. We can often prevent or delay the onset of Alzheimer's disease through avoidance of risk factors. So we really want to emphasize that brain health is really equal to heart health. They shouldn't be treated separately. If you have high blood pressure, if you have diabetes, these things are directly affecting your brain. And soon in the predictable future, there will be specific therapies that can change the course of Alzheimer's disease. So key steps in medical care, just want to mention, there are recognition, diagnosis, assessment, management, and referral for resources, and support for caregivers. And there are a lot of different programs, even in existence now that have focused on these, but I do think this is a really a great slide layout of kind of the different aspects of getting a diagnosis through carrying through to dementia care. And that's the end of my set, so up next I will introduce Dr. Bruce Fink, who is my mentor within Indian Health Service. He's a Senior Advisor for Improvement and Innovation, IHS Office of Quality Planning Section, IHS COVID-19 Senior Advisor, CMS and CMMI Learning and Diffusion Group. So Dr. Fink.
Thank you, Dr. Winchester. Can you hear me okay? Am I coming through?
Yes.
Oh, good. Thank you. And I always love hearing you talk about this, about dementia, because I know that this is what every day you're spending with folks living with dementia, with their families, and when you talk about it, it's really from that perspective. And I want to linger on this slide for a minute again to emphasize this notion that as we think about, and what I'm going to speak to a little bit is, okay, how do we think about improving care and services for folks living with dementia and for their families? And I want to linger on this slide for a minute, and these steps that we recognize, that we see there's a problem, and that, of course, doesn't happen that happens outside of the health system usually. That has to do with family members recognizing that there's a problem, senior center, the guy at the post office maybe when an elder comes to pick up mail from the, comes to their post office box, or maybe it's a bank when an elder comes in and is a little bit confused about how to handle money. So recognition can happen in a lot of different places. It might be archival police who respond to a call from an elder who's confused about something. So recognition happens outside of the health system, but it's a really critical first step. Then it ideally leads to sort of bringing them into the health system to make a diagnosis. And Dr. Winchester talked about why that's so important. And then that cascade down from diagnosis to assessment, which is about understanding what's going on from the patient's perspective, from the person living with dementia and their family's perspective. What are their needs? What's their situation? What are the risks? What are their needs? How can we best organize care for them so that they can live well? And that leads, of course, that assessment is so critical because it leads to management and decisions, and often to referrals for resources to help support the individual living with dementia and their family. And I wanted to, and we've called out here support for caregivers because this is just so important and often not very well structured in our systems yet. That the notion that care for, to emphasize something Dr. Winchester said, care for the person living with dementia includes care for those who are caring for them. So how does this, what does it take to do all this? Well, you know, here's a sort of an image of that, right? We have the individual who's living with dementia, Alzheimer's, or one of these other forms of dementia in the community, or in a nursing facility. There's the family and caregivers who are helping support them and help them with their activities of daily living and needs. There's education and support resources for both the individual and their family members. There's elder services, which are in the tribe, and we're fortunate in many of our tribal communities to have such strong senior centers and elder services, Title VI programs, and they're just so important in sustaining elders and their families. There's the medical care that comes in through the health system, but there's also a variety of other community services, social services, but also law enforcement, as we mentioned, even banking services. But there's a concept of the dementia-friendly community, recognizing that it takes actually a community to care for an individual living with impaired cognition or with dementia. So how do we know all this? I wanted to take a minute and talk a little bit about how we've learned how to think about this work in tribal communities. We've really had a long-standing relationship through the IHS with tribal and urban programs to improve the care of the elderly. There have not been a lot of resources associated with this until now, but we had a series of long-term care grants for about 10 years that really helped build some of the network of long-term care facilities and services and support that network, that largely tribally run network, almost entirely tribally run network of long-term care. We had a whole series of conferences over the years, often co-sponsored with some federal partners to share best practices. And then engagement trainings at Title VI directors meetings, at the National Indian Council on Aging meetings. There's been various trainings in support of palliative care, fallen injury prevention. And of course, Dr. Winchester serves as our chief clinical consultant, and in that role, she's out often consulting with IHS tribal and urban programs around elder care and with clinicians about elder care across the country. And in all of that engagement, and thinking back to the previous slides about the steps in care and those in the community involved in care, here's how we're beginning to think about what we need to do to improve care of individuals living with dementia. And we're really excited to put these ideas out there, but also to engage in consultation and confer to sort of understand better how to do this work, where to put our priorities, what are the best mechanisms. We're looking forward to this next period of consultation and confer to sort of help guide this work. But the four buckets of work that we see now, based on our engagement, is one is sort of an increased recognition of dementia in the community. We talked about this. How do we make sure that folks who might be struggling with memory or with activities of daily living kind of come to the attention of the health system and can get the diagnosis and as a ticket, diagnosis, assessment, and then resources they need and the family needs. The second is, when they come to is how do we improve diagnosis, assessment, and management in IHS tribal and urban Indian health programs. That's about what happens when they get there, when they get to the clinic or hospital. Are they going to get a good diagnosis, a clear diagnosis, an accurate diagnosis, and then a good full assessment, and be able to get the resources they need and the support they need. And then we're very interested in understanding how to put all this together, recognizing dementia in the community, bringing the resources to the individual through the health programs. And we see this as occurring in the tribes in comprehensive models or tribal models of comprehensive care for persons with dementia. And we think we can learn from tribes who put all the pieces together. There are a number of tribes, including there are a number of tribes that are doing this now, and we can foster a lot of learning from each other. And then finally, we do need to use data to understand both the impact of dementia, but also the impact of our interventions. How are we addressing, what are the changes we're making improving the care? So that's the way we've been thinking about this. This is what we bring to the Consultation Confer, and we're just really going to be really interested to hear over the next week the guidance that comes through Consultation and Confer. And finally, I did want to say that, we're not operating in a vacuum. I've just identified here, we've been doing a bit of a environmental analysis, identified here some of the federal programs that are addressing, both programs and just services that are addressing Alzheimer's and forms of dementia in Indian country. The CDC through its Healthy Brain Initiative Roadmap and a BOLD grant to develop resources, educational resources. NIH and NIA through Alzheimer's Disease Research Centers, some of which are very active in Indian country, including in Arizona and Wisconsin. There's HRSA funds, the Geriatric Workforce Enhancement Programs, and some of those are working with tribal partners around dementia. ACL has, of course, funds the senior centers and caregiver support, but they also have a small number of Alzheimer's Disease Program Initiative tribal grants. And finally, the VA has been a really strong partner with IHS, bringing training and caregiver support to Indian country. So these are some of the resources. I didn't mention that, that Alzheimer's Association has also been active and engaged with tribes, and NIHD has been involved as well in work to promote awareness and understanding of Alzheimer's. So there's a lot going on. We're going to try to integrate with existing resources, not duplicate, but complement as we think about with you all about how to deploy the new resources that have come in to address Alzheimer's. And with that, I'm going to close. I'm going to turn this over to Mr. Rick Haverkate to sort of shift topics from Alzheimer's to HIV, another opportunity we have. And I'll turn it over to you, Rick.
Great. Thanks, Dr. Fink. I appreciate all the predecessors talking about the important work that you're doing with healthcare and Alzheimer's. Lucy, if you don't mind, I'll ask you to advance the slides for me. Next slide, please. At the overview. Again, I'm Rick Haverkate. I lead the National HIV and Hepatitis C program. So I'm going to give you a brief overview of what we're doing in Indian country around HIV. And explain a little bit what ending the HIV epidemic plan for America is all about. I'll let you know a little bit about some of the tribal listening sessions and the engagement we've already interacted with. I'll talk about some of the education priorities, and we'll go into a Q&A session. Ranyak will lead. Slide, please. First, let's talk a little bit about the program overview. Next slide. I'm going to give a brief update, and this is based on the latest available HIV statistics for American Indians and Alaska Natives. I'm using data from the Centers for Disease Control and Prevention. I'll refer to them as CDC from now on. And this is data reported through December 2019, and it includes, but it's not limited to, data from the Indian Health Service. Like all health system providers, all of our IHS facilities report notifiable diseases to their respective state health authorities, who in turn transmit that data to the CDC. The link to the CDC's annually published HIV surveillance report is located at the bottom of the slide. And this figure is taken directly from the National CDC report. It shows the trends of new HIV diagnosis, AIAN, specifically by transmission category. I'd like to point out that 84% of the reported HIV diagnosis in AIN people were among. Probably not too surprising. It follows a lot of the national trends. However, I think it's really important that you see that's where our highest impact of new HIV diagnoses. Most of the documented HIV transmission among these men was from male-to-male sexual contact, accounted for 77% of the new diagnosis. Second most common transmission route was from injection drugs combined with male contact, which accounted for 13% of the diagnoses. Among AIAN women, the route was heterosexual contact, which accounted for 56% of new diagnoses. That was followed by injection drug use, which was 44%. And although there is a slight variation from year to year, the new HIV diagnosis trend for AIN between 2014 and 2020 is what we consider to be stable. The diagnosis rate is approximately 8 per 100,000 for American Indians, compared to 5 per 100,000. Slide, please. In that same CDC report, the death rate among AIN people living with HIV in 2018 was 30% lower than it was in 2014. Yeah, you heard me, right? Lower. Our death rate was lower by 30% in 2018 than it was in 2014. And while we can't infer any kind of specific causation on a national scale, you know that our larger IHS-operated HIV treatment programs like the Phoenix and the Gallup Indian Medical Centers show really outstanding HIV testing, approach to care, and viral suppression outcomes among their HIV patients. But I just want to note there's some good news out there, folks. Next slide, please, Lucy. And if we look at HIV diagnosis trends by age between the years of 2010 and 2017, we see a 67% increase in new diagnosis among those AIAN men, 25 to 34. That group I talked about earlier, we're seeing most diagnoses, we saw an increase of 60. And we see an 18% decrease in AIAN 55 years and older. So a little more good news for us, right, in that older age group. In that same period, we see a 54% increase in new HIV diagnoses in men, while the rate for women remains. I'm throwing a lot of data at you, but I'm looking forward to any questions you might have for clarification. But it's important to note that the gender category is binary, meaning the data only looked at male and female. And as of this report, there were no data categories for transgender or gender non. But you know, we're working really hard at IHS and all the way up through the levels of HHS and government to make these additional categories options in the future. We get a lot of questions about other categories besides male and female. We don't have that data yet, but folks, we're really working hard. It's also very important to understand that small data or populations like ours can lead to a large percentage increase or decrease from year to year. So please keep that in mind when viewing large fluctuations that happen in a single. Next slide, please. So finally, let's talk about why we're here today, about ending the HIV epidemic, a plan for America, and the new $5 million that Congress allocated to IHS. EHE, as I'll call it from now on, ending the HIV epidemic, is a bold plan announced in 2019 that aims to end the HIV epidemic in the U.S. by 2030. So agencies across the entire U.S. Department of Health and Human Services, including IHS, developed an operational plan to pursue that goal, accompanied by a request for additional resources from Congress. That includes the $5 million in new funds to IHS fiscal year 20. And the plan leverages critical scientific advances in HIV prevention, diagnosis, treatment, and outbreak response by coordinating the highly successful programs, resources, infrastructure of many HHS agencies and offices. First phase, the initiative is focusing on areas where HIV transmission occurs most frequently. And that's in 57 geographic focus areas with an infusion of additional resources, expertise, and technology to develop and implement locally tailored. Hopefully this will become more apparent as we get a little bit further into the slideshow. Next slide, please. Go. Oh, one more. There we go. The initiative seeks to reduce the number of HIV infections in the U.S. by 75% by the year 2025, then by at least 90% by 2030, for an estimated 250,000 total HIV infections reported. For the last many years, we've been seeing about 40,000 new HIV diagnoses each year, and we want to get that reduced by 90%. So data tells us that most of the new HIV infections occur in a very limited number of counties and among very specific populations. And that gives us, or gave us, the information needed to target our efforts to those locations. We have the tools today, the HIV epidemic. We don't need any more miracles. We don't need any more breakthroughs in science. We have the tools and the information today. But landmark biomedical and scientific research advances have led to the development of many, many successful HIV treatment regimens, prevention strategies, and improved care for persons. The initiative to end the HIV epidemic includes things like pre-exposure prophylaxis, call it PrEP. It's a daily regimen, a combination of two drugs put together in a single pill. People who are at risk for HIV take this pill once a day, more than 99% effective in preventing HIV effects. We also promote syringe service programs that have proven to dramatically reduce HIV and hepatitis C risk. And we have incredible new treatment therapy for those who are living with HIV, antiretroviral therapy. For people living with HIV, they take their medicine as directed. They can get to an undetectable viral load, which means we cannot detect the HIV blood. That gets them to the point where they are virtually incapable of passing the virus to anyone else. Plus, it keeps them healthy. They live long, productive, healthy lives with a life expectancy nearly identical to those folks without HIV. So the initiative leverages lots of science, brings in all the HHS agencies, CDC, Health Resources and Service Administration, IHS, National Institutes of Health, the Office of the HHS Assistant Secretary for Health, and Substance Abuse and Mental Health Services. The coordinator for this is the HHS Office of the Assistant Secretary, specifically the Office of Infectious Disease and HIV. Next slide, please. I mentioned earlier some of those geographic focus. Here you see them on the slide. And there's 48 counties, plus Washington, D.C., and San Juan, Puerto Rico. More than 50% of HIV diagnoses occurred in 2017. And in the planning stages of this, the folks including IHS director at the time, got together and devised a plan that would target the areas of greatest need, but they also wanted to look just beyond a lot of those urban dots that you see on the screen. And they wanted to make sure that they included the rural states where there was a very high number of HIV transmission. So you see the blue states there, the light blue, especially in the south and Mississippi Valley area, that have a large population of rural folks with a higher than usual rate of HIV diagnosis. So we included those as well. But that's where our main focus is set to be for this first phase of ending the HIV epidemic. Slide, please. And during the planning part of EHE, the IHS was encouraged to use some of our minority HIV/AIDS funds, which we compete for every year, to put those towards getting Indian country ready for EHE. So we funded a notice of funding. We put out a notice of funding opportunity for the tribal epicenters so they could help us get ready for that response pillar. 9 of the 12 epicenters applied. All were awarded funds ranging between $100,000 to $250,000, helping us look at things like diagnosis, treatment, prevention, and a response to new outbreaks. And you can see by the comparison here that we cover the entire country, but we really do bring attention to those previously mentioned 57 geographic hotspots. So we are well prepared get Indian country on track with. Next slide, please. Despite the game-changing developments in HIV prevention and treatment tools, not everyone is benefiting equally from these. So new infections we know are highly concentrated among men who have sex with men, minorities, especially African Americans, Hispanics, and American Indian and Alaska Native, those who live in southern U.S. And because of the data we were able to get, and the data I showed you earlier in this presentation, the new National HIV Strategic Plan specifically mentions American Indian and Alaska Native men between 25 and 45 who have such high rates of new diagnosis. So we are part of the new plan, part of the new national plan, and we appreciate that our voices are heard, our data is seen, and action is being taken to address it. But I want to talk about stigma a little bit, which can be a debilitating barrier preventing people living with or at risk for HIV from receiving the health care, services, and the respect they need to serve. And that stigma still tragically surrounds HIV. Responding to HIV is not just a biomedical, but a social challenge. We know that effective interventions have driven the number of HIV infections down to the 40,000 per year I mentioned, the lowest level ever, but new data show that our progress reducing the number of HIV infections has plateaued. So we've really got to get to work. Concentrate on some of the other things that we know contribute to the HIV epidemic, including things like the opioid, hepatitis C. We know that 1 in 10 new HIV infections occurs among people who ingest. We know that our nation faces an unprecedented opportunity we once thought possible. This is one of those things that truly is unbelievable, that we can end the HIV epidemic. So we know that the most powerful HIV prevention and treatment tools in history are now available. Areas where HIV transmission is occurring most rapidly can also be identified. By deploying those tools swiftly and to the greatest effect possible, we can end the HIV epidemic in America. Next slide, please. One thing I might not have mentioned yet, you might have heard it, I might have slipped and said it, but IHS, the Indian health system, is charged with ending both the HIV epidemic and the hepatitis C epidemic, a syndemic. The other HHS agencies are charged with ending the HIV epidemic, but IHS has been working with our partners in Indian country, our tribal and urban partners, for the last 10 plus years, working very hard on the hepatitis C and HIV. So we know we can do this. It's going to take a lot of effort, some more resources, but we know we have the willpower in a lot of our areas. So our job is to get the resources there, encourage folks, sort of give you the tools that you need to help us end both HIV and hepatitis C. So a little bit about the EHE structure. Slide. Go. So at the center of it is the idea of having the right data and the right tools. We know we've reached that. We know we have it there. We know we have HHS leadership, IHS, tribal, urban, state, local, philanthropic. They're all there helping us with this process. We know what the priority areas are. I'm going to talk in a minute about the key strategies about the HIV epidemic, which are diagnose, treat, prevent, and respond. And you have the funding. IHS has been competing successfully over the last 12 years for Minority HIV/AIDS Fund, and now we've gotten word that we'll be receiving $5 million towards ending the HIV epidemic. So we're very excited about this, and that's the next, please. Understanding how this all works is impossible unless we bring in the idea of the social determinants of health. And those are things like neighborhood environment. For example, are buses accessible? How far away are health clinics? How accessible is a pharmacy? Do people have a place to sleep and to live? Education. What is the health literacy of information? Economic stability means, are individuals employed? Do they make enough money to support themselves, to support their family? And the social and community context, which talks about who is supporting people across the health and service spectrum. Do people have access to housing? Are they connected to their indigenous culture? Finally, healthcare. Do all providers know about PrEP, for example? What are provider biases? Do some of our folks have biases against promoting or prescribing things like PrEP? And what are the complete services being provided to people living with HIV? Do people have access to counseling services? Just a couple of handfuls of suggestions of how the social determinants. So let me get to some of those key strategies that Dr. Tote mentioned them earlier in the discussion. One back, there we go. We want to make sure that we can diagnose all individuals with HIV as early as possible. We know that more than 160,000 Americans are unaware they're living with HIV. Back one slide, please. We know that over 160,000 Americans are unaware that they're living with HIV. And oftentimes, that's how HIV spreads, is between people who are unaware of their status. If we get people to be aware of their status, get them into testing, screening, well, we can get those who are living with HIV into care. We can get those who are at risk but not living with HIV, be more conscious of the prevention method. So for those people who do test positive for HIV, we can get them into care and treatment. In fact, we have to keep them there. We have to give them effective treatment. We have to get it to them rapidly. They shouldn't be leaving our clinics without an appointment or drugs in their hand to treat their HIV. I mentioned it's just a small amount, maybe sometimes one pill a day, can get people to the undetectable viral load within a matter of months. If we get them there, keep them in care, get them engaged, give them the support they need, navigate them through the system, we'll get them to a point where they're incapable of transmission. And then the third pillar is prevention. We know that condoms work, we know education works, but we have new biomedical tools like pre-exposure prophylaxis, that pill once a day. That's more than 99% of keeping people from acquiring HIV. We also want to talk a lot about safe syringe programs where applicable. And then finally, responding, number four, fourth pillar, respond quickly to potential HIV outbreaks to get needed prevention and treatment services to people who need them. That's one of the reasons why we started off with funding the tribal epicenter pillar. So using data to identify where HIV is spreading most rapidly, guide decision-making to address prevention, care, and treatment needs. That's what data does for us. Supporting jurisdictions to establish local teams to the success of the initiative who will work with the community to design locally developed, locally tailored plans to expand HIV prevention and treatment service. Next slide, please. So I wanted to tell you briefly a little bit about the tribal listening sessions we've already engaged in. Early 2020, we worked with National Indian Health Board and the National of Urban Indian Health to do a series of tribal listening sessions. Today, for the sake of time, I'm going to go over just the NIHB tribal sessions. I'll recap the NCUI urban sessions on a future call. But a total of 66 people participated in the NIHB-led discussions, 59 community members and 7 support staff. We talked with people who were from the MSM, or men who have sex with men community, two-spirit individuals, transgender folks, service providers, and general community members. Slide, please. 66 people and support staff from across the country participated in 5 different sessions. IHS staff attended as observers, were asked to listen only, although there were points where participants did ask them to engage and respond to specific. NIHB staff were present to facilitate the discussion, to listen to participants, and work with on-site transcriptionists. They helped to organize travel and on-site logistics and ensure that all participants were comfortable with their participation. And all listening sessions, these were all listening sessions with only open-ended questions posed to participants by NIH staff to just fuel the discussion. So 4 discussions were recorded and transcribed for analysis, and then notes from the general audience session were used for reporting and recommendations. Responses were then coded reviewed for themes, following a grounded theory approach for qualitative data. IHB submitted those reports back to me, and next slide, please. I'll go over briefly what they talked about. So in the stigma column, community-based stigma, according to our participants, still remains a driver of the epidemic in India. Need for competent services, and our folks said that there are many services captured within the HIV spectrum of care, and broaden further when the scope of case management services included across the listening section. That echoed a sentiment that a lack of competent services is keeping people from accessing or enjoying the benefits of prevention, testing, treatment. So, reporting back to you what our listeners said. Next column was the need for increased and focused training. The training and staff development are key strategies to increase the knowledge and competence of participants. It was mentioned throughout all listening sessions. Participants largely believe that training should be developed and then required for IHS employees. Training topics and would be helpful to include, but not limited to, things like confidentiality, cultural fluency and relevancy, HIV integration, and the intersection of HIV and other epidemics. Finally, the last overriding theme was the need to standardize efforts and policies. Next slide, please. Back over to Dr. Roniak. I look forward to helping people understand some of the real quick issues I brought up here. Go ahead, Dr. Roniak.
Thank you, Rick. We appreciate that very much. So as Rick was mentioning, we are very excited about this opportunity, and what we're looking at is exploring how IHS might use these available fundings to support our efforts, and there's a variety of key strategies that we are focusing on. And so we want to ensure that this learning session was able to provide enough background for folks to kind of take in the information, think about it as they prepare to provide input to us, as the input is very important for us. So next slide, please. As we move to the question and answer session, I realize that we're short on time. I see that we've had quite a few questions in our chat box, so thank you very much for those questions, and thank you to our SMEs and Dr. Tote for responding as quickly as possible as we're moving through this. So we'll want to open up for additional questions if folks want to put them in the chat box, and let me just check in. Operator, are you online? Okay, looks like we might be having some technical difficulties there, so apologies. If you are putting a question in the chat box, if you can please remember to list your name, the IHS area, and the tribe for our record, that would be extremely helpful. And let me just check over with my technical team. It looks like we have answered all questions that came in the chat box, but I also want to give people time as I see them typing right now. So we will allow that. While we are doing that, I'm going to ask Ms. Lucy to move to the next slide, and we'll just kind of work through those slides as we wait for the questions to come in. Just to share a few upcoming dates, we do have several tribal consultation and urban confer opportunities. So our next one will be on Tuesday, next Tuesday, April 13th at 1 p.m. Eastern Time. That will be a 90-minute session. We will go over specifically Alzheimer's disease. We'll talk a little bit more about and take a deeper dive into our efforts there and provide some more information for folks to kind of chew upon and think about and be able to comment on. And then we will open it up for approximately an hour for feedback, input, and things of that nature. We will then move on to tribal consultation for the 15th of April, and that will be focusing on our ending the HIV and Hep C epidemic. And then the following week, we will be also hosting Urban Confer for Alzheimer's disease on the Tuesday the 20th, and then for our EHE efforts on Wednesday the 21st. Again, as noted in the chat, we do have a DCCS tribal consultation and urban confer website where we will be hosting all of the recordings, putting the PowerPoints up as the events occur. We're also scheduling some listening sessions in late April and May, so those will be going up as well. So I see quite a few questions coming up here real quick. Let me check to see if we can answer some of these. So it looks like, Dr. Fink, there may be a question there in chat. May I turn that over to you?
Yes, I'm just looking. I don't know that it's a question. I think Valerie, oh, I see, about hitting certain areas. No, Valerie, for the Alzheimer's work, we'd like to be nationwide because we know that in every tribe, every community, there are folks living with Alzheimer's and people taking care of them. So we're going to be trying to be as broad as we can. I think when we start to talk about potentially funding some tribal models and learning from them, you know, there we might end up, we'll try to be we'll look for the consultation and confer to help us decide how to allocate those resources. By definition, they can't go everywhere. I think epicenters are a terrific resource for addressing Alzheimer's disease. I think there's been some really interesting work recently thinking about Alzheimer's disease not just as a personal problem or a problem for a family, but as a public health problem. And I think the epicenters are really well positioned to help us think about that as a public health and to support tribes to address dementia as a public health problem. So we're excited about that.
Thank you, Dr. Fink. And Ms. Ferreira, I also see your comment in there. We will take that for the record, and it also aligns with what Dr. Fink was talking about, the importance of our tribal epicenters, even if we are focusing on other type of public health issues. So thank you for that. I'm going to go ahead and move on from our question and answer session, but if you do have others, please feel free to put in there, and we can circle back with you individually on that. Lucy, can you move to the next slide, please? Just as a reminder, as our tribal consultation is open, we do have 2 subject lines. So if you are putting in comments, please use the subject line Alzheimer's Disease Initiative Funding and submit those to either our consultation at ihs.gov or urban confer at ihs.gov, whatever is appropriate. We're open for consultation comments until June 1st, and the same goes for our ending the HIV and HCV epidemic funding. Please use the subject line and submit accordingly. Lucy, next slide, please. And we just wanted to also share our program leads, so please, anything that's elder care, send it to IHS-DCCS at ihs.gov. Anything that may be National HIV-HCV program to Mr. Haberkate, and we'll provide his email. And again, just as a reminder, we will be putting the slides up on our website, so there you will have those as well. So right now, I thank everyone for their questions, their comments, our speakers, our subject matter experts, so thank you very much. We really appreciate that. I will turn the program over to Dr. Toth for our closing remarks. Sir?
Thank you, Dr. Ronyak. I want to thank you all again for making the time to participate today. I appreciate all of our callers and your continued dedication to meeting the IHS mission to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. I also want to acknowledge our subject matter experts who have joined us today and recognize the work they do for Native communities. It has been great to share this information with you today as we prepare to hear your feedback during the upcoming Tribal Consultation and Urban Confer sessions for each initiative. IHS values the input of our tribal partners and is committed to tribal consultation. Thank you again, and have a great day.